Now, the interesting part is that it is not necessarily means that if the patient is on ventilator, that means he or she is not going to survive. If you have a financial problem, how long will you keep on taking the drug if they are especially costly? So we will try to find some trust, those who can help out the patient. Initially, it was a domain of a X-ray doctor, what we call as the radiologist. But now it has taken over, at least in a ICU, it is taken over by the intensivist, what we call as the ICU doctor specially. So that skill we have acquired in the last 15-20 years. And it has spread all over the India, each and every ICU. And it has helped us to save a lot of patients' life.
You have illnesses and then you go to a doctor, you go to a hospital, and then you hear ICU, and immediately there is a certain level of stress.
Yeah.
What exactly does ICU care mean? Hi, I'm Jagu, and welcome to the Good Doctors podcast by Zynovashalbyhospital. When we hear the word ICU, most of us think fear, beeping machines, closed doors, worst case scenarios. But what really happens inside an ICU? How much of it is crisis and how much of it is careful life-saving science? Today we're speaking to Dr. Ravindra Zore, Chief Intensivist and ICU Head at Zynova Shalby Hospital, to understand what modern critical care really looks like and how it has evolved in today's era. If you've ever felt confused, overwhelmed, or scared about ICU care, this conversation is for you. We have with us today Dr. Ravindra Zore from Zynova Shalby Hospital. Ravindra, thank you so much for doing this with us.
Thank you for inviting me here.
Entirely our pleasure. Now, usually we're talking about illnesses, treatments, things like that. Today, we want to change the subject matter, or at least the tone of it a little bit, and we want to specifically talk about a room.
Okay.
The ICU in this particular case.
Yeah.
Because you have illnesses and then you go to a doctor, you go to a hospital, and then you hear ICU, and immediately there is a certain level of stress.
Yeah.
What exactly does ICU care mean? Because when we hear ICU, someone admitted to the ICU, individuals there for maybe days, there is stress, there is emotion involved. Explain to us in layman's language, what is ICU care? Does it automatically mean everything is critical?
So to start with, ICU, the full form is Intensive Care Unit, or sometimes they call CCU, that is a Critical Care Unit. So both these words, the intensive and critical, they have a little psychological effect on the relatives. In our sense, if you ask me, the ICU or critical care unit, usually there are two types of patients. Those patients who are actually serious. Okay, so for example, any patient whose blood pressure has gone down, or those who are not, they are very breathless, or those who are not passing good amount of urine. Okay, so these kind of patients, they require monitoring as well as the active intervention. What do you mean by active intervention? Is that we put a lot of lines, we have all the monitoring things, everything is there. But there is the other set of patients also. Say, for example, those who are not critical at that point of time, but we expect that they might deteriorate. Classical example is the person who is a chest pain is having a heart attack. There, at that moment, patient is not that serious. But we assume that, okay, he might deteriorate in a matter of minutes or in a matter of hours. So there we keep the patient in ICU for observation. So if something goes wrong, we can intervene immediately.
Fair.
Again, the stroke patients, those who are with the paralysis patient, sometimes they have the paralysis, they recover, but we keep them in ICU because there is a chances that they can get another bout of paralysis again. So we have to intervene. So there are two sets of patients, those who are actually very serious and those who we think that they might get serious. So for those kind of patients, we keep them in observation. So it does not necessarily mean that ICU means the patient is actually serious. Sometimes we keep them for observation.
We can call it a safety margin.
Safety margin, absolutely. Exactly. Like after the surgery, after the operation, we keep the patient for a safety margin. Those patients, they are not serious.
Fair.
But we have to keep them in ICU for observation, for safety. If something goes wrong, we should be there to intervene. So that's why.
Over the last, let me put a timeline of 15 to 20 years,
Okay.
How has the ICU changed? What advancements are there in terms of technology, in terms of room, in terms of care?
Okay. So again, so the things have changed in a terms of technology and in terms of knowledge. So medical field keeps on changing. If you can ask me daily or yearly also. So technology wise, I'll give you a simple example: the ECMO,
Hmm.
what we call as the extracorporeal membrane oxygenation. In a simple terms, we give the oxygen from the outside.
Hmm.
Okay. Now, this technology was not there 15, 20 years back. At least not that as easily available.
Hmm.
But now it is easily available everywhere.
Hmm.
Okay. At the most of the biggest hospital, it's available. So that's one part of technology. And then means that has evolved over a period of time,
Yes.
and it is easily available now. Another simple thing is the sonography machine. Now everybody knows that a sonography machine is available at some diagnostic center only, but now we use the sonography machine in ICU daily for
Okay.
each and every patient,
Okay.
because there are certain things which we can diagnose immediately. Okay. Now, if you come to the education part wise or skill wise, how the doctors have evolved. So all this, for example, sonology.
Hmm.
Initially, it was a domain of X-ray doctor only.
Sure.
What we call as the radiologist. But now it has taken over, at least in a ICU, it is taken over by the intensivist, what we call as a ICU doctor
Hmm.
specialist. So that skill we have acquired over in the last 15, 20 years.
Hmm.
And it has spread all over the India, each and every ICU. So these are the technological and the skill-wise changes which has happened over a 15, 20 years. And it has helped us to save a lot of patients' lives.
Fair.
Yeah.
We're discussing a gradual improvement,
Mm.
but COVID
Hmm.
was almost an overnight thing, as
Yeah.
it were. The concept of ICU became far more prevalent.
Yes.
We are talking about ventilators, the need for
Yes,
oxygen,
yes.
the lack of hospital beds. It doesn't have anything to do with the hospital itself.
Yes,
It's just there was an influx of patients.
Yes, yes.
What changed for you at that point, and how did ICU systems handle the pressure?
So COVID, in a way, what we can say is that COVID, in a way, actually introduced intensive care or the critical care or the, for that matter, in a larger term, the medical care to the layman people only.
Yes.
Previously, it was that okay, those who are sick, their family only knew how the things go, what is the emotional thing or what is the financial problem, all these things. But COVID being an endemic, almost most of the people they were affected. Many people were affected, and everybody was very keen to know what is happening there, what are the drugs, and what is the things are. In ICU care, one thing was very interesting to know that we came to know that our infrastructure we need to develop it more. Surely because of our population. So if you take 1.4 billion, do we have proportionate intensive care beds? No.
Okay.
So that thing has been, whether we are in a process to take care of that. Many hospitals are coming up with the more and more ICU beds availability. Another thing is the technology, the machinery. So many people have taken ventilators. They have taken what we call as non-invasive ventilators, which were not easily available, say 5-7 years back. But after COVID, that availability has increased.
Okay.
So in short, for better care at the lower level also is available.
Excellent.
The important thing is that the insurance part.
Yes.
People were not that much giving importance to the health insurance, but post COVID or during COVID, I think that has changed, which is a good thing, because if you have an insurance, it reduces your financial stress, and you can take a better care at a better hospitals. Okay. And on the contrary, the government hospitals have also been upgraded because of the COVID.
I believe so, yes.
Yeah, absolutely.
Okay.
Because they got a lot of funds, they got a lot of machinery, and that was available in a short period of time.
Okay.
Because of the seriousness of that particular endemic.
And so, given our learnings from that time, would you say that quality of care generally across the board has gone up a little bit, not just number of beds, but quality of care?
Yeah, absolutely. Quality of care has gone up because uh, we saw so many patients, and we learned so many things during the COVID that not only technical aspect, but the emotional aspects also. And because of the availability of simple machines. So, for example, a small hospital which did not have a non-invasive ventilator, the BiPAP machine, now they have.
Okay.
Okay, they have procured. So their quality of service has gone up.
Okay.
Then the people, the doctors particularly, they have become more, emotionally more involved, emotionally more considerate of the patient. And other services, other paramedical services, they have also, because lot of recruitment has gone for paramedical services also.
Oh, paramedical, not just
like cleaning staff, nurses. So initially there was nurses were less. Because of the COVID, the nursing ratio has become better.
Excellent.
Nurse to patient ratio.
Fair. We're more familiar with hospitals than the workings of an ICU specifically. But we keep hearing names like ECMO, like we discussed, a dialysis machine, a ventilator. In layman's terms, because I don't understand what, I know the names, but I don't understand what they do. The main equipment in an ICU, how does it help? What does it do? Could you just run us through it?
So the most dreaded or most scared equipment in ICU, the ventilator. Means there was a concept that if the patient is on ventilator, probably it's a last stage.
Yes.
In a short, this thing, ventilator means you have a lungs which take the air in. We use the oxygen and we throughout the carbon dioxide outside. So exactly that thing is done by the ventilator. So it's artificial. It's a external support for your lungs. Now the interesting part is that it is not necessarily means that if the patient is on ventilator, that means he or she is not going to survive. We have very good sophisticated versions of ventilator now. We have the skill level has gone up. Okay. And the antibiotic support and the other medications which are there in the market, all these things, they help us to save the patient through the ventilator.
Fair.
So this general concept, I think it's slowly it's getting erased off because, say, for example, during COVID, we had so many patients on ventilator. And everybody was like, now if he's on ventilator, he's not going to survive. But those patients, they started surviving. Okay. And it also depends on what is the basic disease. So for example, if there's a patient is of a heart failure and if he's on a ventilator, within 2 or 3 days, he can come out of the ventilator because once his lungs are, there is basically heart failure means your lungs get flooded with the water.
Yes.
And we remove that water through the urine by giving some injection. Once that is done, the patient comes out of the ventilator within couple of days. So it does not necessarily mean this concept or this fear of the general people, layman people, that the patient is on ventilator. So that means he is on the last stage. That should not be think of now.
Fair.
Okay.
The ECMO or the concept of multi-organ failure support. What are those in the ICU?
So multi-organ failure, in short, means you have a big organs like heart, you have a liver, you have a kidney. Once they start failing, okay, then we call it as a multi-organ failure. And each and every organ of this, say for example, for lungs, as I told you that the ventilator supports the lungs. So the dialysis machine supports the kidney. Support means it basically takes over the natural kidney function on its own. Okay. So all these supports are important when your body is going through a lot of stress. Say, for example, you have a bad infection and the patient is gone into septic, his blood pressure has gone down, everything is gone down. So there we give the antibiotics to kill all the bad bugs. Okay. But that antibiotics, they take time. So during that time, say, for example, 48, 72 hours or whatever time, we need to support the body. Say, for example, kidney is not making urine. So through the dialysis machine, we filter the blood, we take out all the toxins, which are usually removed by our kidney. Okay. So those toxins are removed by the machine and the better blood is put back into the body. That is the basic simple dialysis concept. Same with the ventilator, that we give the oxygen to the body and we take out the carbon dioxide from the body.
Fair.
So once your body starts recovering, okay, slowly, gradually, these organs, they start recovering. And then one support we can remove that support. Okay. And then, so all these machineries, basically, they help us to keep the body supported during that crisis period.
The ICU is also an emotional shock.
Yeah.
For the patient, for the patient's family.
Yes, yes.
And so emotional shock could automatically mean in some cases a resistance to admit.
Yes.
But there is the concept of early intervention.
Yes, yes.
So how do you balance between the two? When does a family or a patient decide that now is the time to go? And it could be hospital, it could be ICU, versus let's wait and see what happens. And okay, but now we should go now. How does early intervention help, and how does one decide now is the time?
Okay, so if I understand your question better, that you mean to say when the patient relative decide when to go to the doctor, you mean to say that?
No, I mean, so a doctor, I'll go to a GP.
Yeah, GP, of course.
Okay, but at what point do I say this is getting critical enough that not only should we be in a hospital, we should be in an ICU?
So that
what are the markers?
So markers is there are certain markers for what we call as the ICU admission criteria. So if your heart rate is going up, normally it's between 60 to 90. If your heart rate is going say 110, 120, your breathing rate is high. Normally it's 16, 20. If it's going up to 25, 30, your blood pressure is fluctuating. So all these things, they point that the patient requires, or if your oxygen levels are going down, all these are pointers that the patient should be kept in ICU. Okay. And as I told you in the initial part, sometimes everything is fine, but still we keep the patient in ICU. Now their relatives can get a little confused why my patient is in ICU. But as I told you, say for example, a patient is having a heart attack, everything remains normal. The heart rate is normal, blood pressure is normal, oxygen level is normal, but still we keep those patients in ICU because they can deteriorate any point of time. So for that patient, we keep in ICU observation because we anticipate that something might go wrong. It's not necessarily it will go wrong only, but sometimes it might go wrong.
So safety margin.
Yeah, safety margin. Yeah. So that is the one thing. Now, emotional aspect, it's a emotional, stress for relatives also because nobody wants him or his relatives there in the ICU because, as I told you, that the ICU means, it's a red flag for everybody. For that matter, hospital is a red flag for everybody. Nobody wants to come to the hospital, and that too. ICU is one or 10 steps ahead of that. So that's for relatives. And we understand that. So that's why we do the counseling. We explain them what is the critical situation of the patient, how are we going to tackle it, and in a roughly manner, what are the chances of patient coming out of it. Okay. So that is the one thing. It's challenging as a doctor for us also. And personally, I experienced that during my COVID period.
I can imagine.
Because patient was talking and then you put him on a ventilator and then they did not come out. So it's like, so that was a stressful situation. So for relatives as well as for doctors, it's a emotional stress for both the parties. For relatives, it's more because they are emotionally, because they are their close relatives. So they are emotionally. But as a doctor, we try to, because now the concept is changing. So initially the doctor was like, technical guy. You give the medication and you treat it. But now we are changing over a period of time. We try to understand the social, economic aspect of the relatives also. So for example, financial. The finance is a big thing. All these things in ICU, they cost a lot. Okay, they cost a lot. So sometimes even if you want to do something, the financial constraints are there. So we try to help them out with the various methods. So that can, that sometimes make them feel little better.
Fair.
Okay.
And actually, we're discussing this from the point of view of ICU admission and what happens before that. But let me flip it to post. There has been an ICU admission. Now there is a feeling of helplessness often enough. We don't know what's happening inside the ICU. What are the correct questions to ask? What is the kind of information that we should request so that even the patient's family or immediate caregivers are in a position to feel informed and involved?
Yeah. So that's what we call as a counseling. So we do patient-related counseling every day. At least in the morning, we have Once all the consultants round, the concerned consultant rounds is done, we do a group discussion with the relatives. Now the questions about what questions should relatives ask us? Okay, the first thing, of course, the natural question comes around ki, how is or she doing? That is the basic question. And then their thing is that they will ask us ki, what are the chances of him coming out?
Yes.
So these are the two basic things. So if you tell them the first thing, okay, your patient is doing good, then the next question comes ki, when he will come, he become better. The next question comes ki, how much time will he or she take to come out of it? Now these are basic questions which they ask us. I think if I am a relative, I'll take a little time to form my questions in a 1, 2, 3, 4, 5 manner. Of course. So if one of my relatives is admitted, of course, the first thing should be ki, what has happened with my patient. So you come to know what is the disease, whether it's a stroke, whether it's a heart attack, whether it's an infection. So if the doctor says it's an infection, so we can ask you what kind of infection. So if we have information as a doctor, if I have infection, because this is a ABC infection,
Sure.
they can give us the relative can come to know this is that kind of infection. Then the next thing should come ki, what are we going to do with that? So the plan of action, whether we are going to give medications or whether we are going to observe or whether we are going to do some interventions. Okay, so all those things. And then ultimately the thing should be ki, what is the prognosis? The prognosis means what are the chances of him getting better?
Fair.
Okay. And the important thing is that in certain cases where the survival chances is the one question should be there, and the quality of life. Quality of life. So for example, a stroke patient, they might survive, but whether they will be able to walk, they will be able to talk, they will be able to eat, or whether they will be able to do their routine things on their own.
Fair.
Because all these things become important after the discharge is done.
Yes.
Because if you know that your patient is going to remain bedridden, then you will need to arrange the things at home.
Absolutely.
So if I am a relative, I'll take a little time. And if you arrange this question in a 1, 2, 3, 4, 5 times, so then it becomes easier for you also as a relative to get the pointed answers from the concerned doctor.
And so then it's a good way to provide information.
Yes.
If they take it step by step.
Yes, absolutely. What is the disease? What are we going to do? Then what are the chances? If he survives, what will be the quality of life and everything?
Perfect.
All those things.
Okay. And that's literally an almost obvious template. Each individual case will have some unique items which the doctor will address as and when.
And as you say, for example, if the patient is there in the ICU, say for 3-4 days, over a period of time, as a relative, you also come to know what the things are happening. So if you want more, nowadays there is the information is available easily. So you can go and you can read and you can ask more questions about the thing which you want to know.
Isn't that a double-edged sword? The Dr. Google situation, I have seen it go both ways.
But then, see, you can't avoid it. Means if I am a doctor, I won't be able to understand everything. So if my relative is admitted with someone else, I will also try to find out what is happening.
Sure.
Okay. So there, I am not in the role of a doctor. I am in the role of a relative. So it's fair enough.
Fair.
So that's not a problem. As long as you have a trust in your doctor, I think no doctor will avoid any questions from the relatives.
Fair.
And of course, the one important thing is the financial. That question should also be there.
I very much want to come to that. ICU admission is immediately associated with high costs.
Yes.
Also, unfortunately, discussions around life support.
Yes.
Now, there is the realistic chances and there is the aggressive treatment. And in an ICU, how do you process that kind of decision? Because you also know the clock is ticking. You also know the bank account is ticking in some way. So there's so many factors you need to take care of.
Yeah, I told you that now the doctors are changing from mere a technical person to we are becoming more and more human in that we take into consideration the socio-economic aspect of the patient also. Now, about the financial point. So that depends on, as you said, how much aggressive to go or not. So that changes from the patient to patient. So for example, if you have a young patient, then we give all the options available. We keep all the options available on the table. There we don't think about the finances, but that part becomes now that that is the responsibility of the relative, because
Fair.
if there is something to be done, we will tell this is to be done, and we will give them a this is the kind of a cost you will have to bear.
Is there a transparency in cost?
Absolutely.
Okay.
Absolutely.
Okay.
So we always give a range. It's not like you buy 1 to 3. No,
Yeah.
we give from here to here. It can go.
Okay.
Okay, because whatever we plan usually it doesn't go in that same manner only.
Yes.
So for a young patient, there we don't compromise.
Okay.
Because then that the finance part will be taken care by the relative.
Yes.
Okay, because we don't want to miss out any chances to be given to that particular patient.
Absolutely.
For old age or for those patients where they have a basic disease which are not curable, say for example cancer, or a person who is a paralysis person who is lying on the bed for a long period of time and they have these complications. If that sort of patient comes, there we try to counsel the patient, say, this is the cost and we don't know what will be the final outcome. Because again, as I told you, the survival is the one thing and the quality of life is the one thing. So if the patient survives, but if the quality of life is not good, then it becomes a burden for the relatives also. So there we try to explain them how aggressive you want to go.
No, fair. And in the ICU, often enough, it's a fight for survival.
Yeah, absolutely. It's a fight for survival.
But if we take that a little, and that ends up being the focus, but if we take it a little forward and say optimistically, positively, things work out, then we have to worry about
finances.
Post-care.
Post-care, yes.
And what are the challenges, emotional and physical, that invariably patients and families deal with, and how does one process that? How does one deal with that?
Yeah. So the one thing is that once the patient comes out of the ICU, that means he's getting better.
Yes, absolutely.
Okay. So that gives them a kind of a little relaxed thing. Okay, fine, our patient has become better. Again, the best example is again the heart attack, because that is the one very feared disease.
Absolutely.
So once say for example, heart attack patient get better, then the part comes about the post-recovery. So there we explain them now what should be your diet, what should be your exercise things. And the most important thing is taking the medications on the time.
Yes.
So all those things, again, that changes from, say for example, in paralysis patient, the physiotherapy takes part, the exercise.
Yes.
Because that part of the body which is now not functioning well, if they take a regular exercise, then there can be recovery. Okay. So those things, say for example, surgical patients, say for example, a bypass patient who has undergone a coronary artery bypass for a heart attack. There we explain them, okay, you have to take care of a wound. Whatever the surgical wound is there, that care should be taken. Again, the exercise part there is also important. There, the exercises are good for lung. So the post-recovery plan again changes from patient to patient.
And the protocols are important, irrespective of the emotional load they're dealing with. The point is the treatment is not over.
Yeah, treatment is not over. Because treatment will continue. All these diseases, they remain with you lifelong.
Yes.
Say, for example, heart problem or diabetes or blood pressure. So the one important point which we stress is that continue taking your medications. And as far as possible, those should be taken on a particular time.
Fair.
Okay, because people... they have a tendency in Indian people, I should not sound like that, but they have a tendency that, okay, now 1 year has passed, now I have no problem, I'll stop my medications on my own.
No, they don't have a tendency, I have a tendency. So I feel it when you say that.
Yeah, I mean, we have seen many, say for example, hypertensive, blood pressure patients.
Yes.
They will see my blood pressure is continuously 120/80, 130/80, so I don't have to take medication. But they don't understand because of the medication, it is normal.
Yes.
Okay, and then they skip the medications and then they land up with all the sorts of complications.
And sometimes the fact that you have come out of a critical illness automatically implies that post-operative or post-illness care and medication, therefore, is going to be lifelong.
Yes.
So,
and then the one, now you talked about the emotional thing, that particular patient is actually scared. Because, see, you have a problem. Say, for example, if you have undergone a surgery for bypass surgery, or you have undergone some surgery for your abdomen, the one major trauma is that how could this happen to me?
Yes.
And to deal with that, we have to explain them, okay, fine, this is the problem. Probably your lifestyle was not good, or probably you did not take your medications. But while explaining those things also, we have to take care that the person should not feel guilty. Okay, this is my fault only.
No,
Even though in that, you have to little spoon feed them, and you have to make them realize in a positive manner. Okay, this has happened, but it's good that you came on time. We intervene on time, so there is not much lost yet. If you keep on doing the good things, if you keep on taking good care of yourself, you will not have much problems in the future. So all these positive things we have to give them. Otherwise, they are in a shock state. Why this has happened to me? Even though they get better and everything.
Fair. But you have to process the thought, the suddenness of what has happened, and it takes a little time to get there.
So, for example, just now we had one patient, no problems whatsoever. A healthy guy in his 50s, doing exercise, everything, and he had a heart attack. Now he asked me, why did it happen to me? So we told him, okay, fine, sometimes it happens.
No, but sometimes it's not in your control. Genetics, pollution, environment. It could go down
and
many
you cannot
roads.
pinpoint one particular thing. But his concern was that I was doing everything right. Still, it had happened to me.
Yeah.
So it becomes a little difficult for such kind of patients to give them a little positive more. So we explained him, you come at a particular time, on a perfect time. Everything was done within a stipulated period of time. So maximum benefit. And there was no function of heart was lost. So all these things.
Fair. And I fully appreciate when you say that doctors have moved beyond being just technical to more the bedside manner has changed. The touch and feel part of the treatment has improved.
Yeah, I mean, we try to understand the patient not as a body, but as a whole.
Excellent. Yes. That is the analogy.
As an emotion, as a psychological, as a financial, as a social. So where does he stay?
Fair.
What are his relatives? What does he do? What is his financial? Because everything helps us.
Yes. Fair.
Everything. The information, it helps us to not only treat the treating is one part, but that treatment, for example, if you have a financial problem, how long will you keep on taking the drugs? If they are especially costly.
Yes.
So we will try to find some trust, those who can help out the patient. So these things we are doing more and more now.
Fair enough.
So our job doesn't end at the discharge. In fact, it starts after the discharge.
Fair enough.
Because till the discharge, patient is in our control. In
Absolutely.
ICU.
Absolutely. Then the hand-holding comes only after that per se.
Absolutely.
Let me come to Zynovashalbyhospital in particular. What are the unique aspects over time you've been executing as yourself, as your team, as the hospital itself, in terms of ICU care, in terms of technology, protocols, team management? How is it working at the hospital? Give us a bird's eye view, if you will.
So Zynova Shalby has evolved from a 3-story hospital to now almost 9 stories. So it has become a 100-bedded hospital.
Okay.
And in that, we have a 17 beds ICU.
Okay.
And it's well equipped. We have all the state-of-the-art monitoring gadgets. We have good sonography machines and dialysis machines we have. But the important thing is, as I told you, there is a machinery, and behind the machinery, there is a human being.
Yes.
So we value more for a human being. So human capital. So our ICU team is, so we have nurses, doctors, everybody's experience. And as I told you, they have a human touch, which is a important thing, while giving a treatment to a critical care patient. Okay. And it's not only ICU is not only about the ICU doctors. We have other teams, like we need a support from, say, kidney doctor or heart doctor or liver doctor. So those are all fantastic people. So as a whole team in an ICU, as a Zynova Shalby, I think we are doing a wonderful job.
That is good.
And that area, I think probably we are the best institute for a critical care.
I'm glad to hear that.
Yeah.
Ravindra, thank you so much. This has been insightful. It's also cleared some cobwebs in terms of how one thinks about this, because ICUs, critical care, invariably means overthinking often enough.
Yeah.
So I'm glad you've given us a process. You've given us an insight from the other side, as it were.
Yes.
And I very much appreciate that.
Yeah, thanks a lot. Thanks a lot, Chaku.
Thank you for doing this
Thank
with us.
you.
If there's one thing we've understood today, it's this. ICU does not automatically mean the end. It means attention, it means advanced monitoring, it means a team working minute by minute to stabilize and support the body. The more we understand critical care, the less we fear it. Thank you, doctor, for helping us decode what really happens inside the ICU and for the work you and your team do every single day. And to everyone watching, here's a reminder: awareness reduces panic. Stay informed, stay prepared, and prioritize health. Always. In the heart of Mumbai stands a name trusted by thousands. Over 1 lakh heart procedures, 200 plus years of combined experience. From diagnosis to recovery, your heart gets complete care under one roof. Because when it comes to your heart, experience isn't optional, it's everything. Zynovashalbyhospitals. Experience you can trust, care that you deserve.